Hello, and thank you for taking the time out of your evening to join us for this Introduction to IVF webinar with Dr. Tom Bamford. Following the presentation, he will be responding to your questions. You can send these through at any time during this evening's webinar via the Q&A panel on the right-hand side of your screen. I'll now hand you over to Dr. Tom Bamford.
Thanks, Sam. So it's lovely to see so many people on the event today. So I think we've got over 160 people registered, which is great, great to see. And as Sam said, any specific questions that I can hopefully help with at the end, I'll take your questions. So I'm Tom, or Dr. Bamford. I'm the medical director of Care Fertility in Manchester, which is quite one of the largest clinics. And hopefully today I'll give a bit of an overview of IVF. It's sometimes quite challenging in these talks because there's lots and lots of different types of treatment that we can support you with, and also different types of patients that come to us, single patients, same-sex male and female couples, and obviously heterosexual couples as well. And so each one of those has an individual treatment pathway in order to be able to support you in achieving a family. But we'll go through the general overview today, which applies to the majority of patients in one way or another. So Care Fertility are the largest provider of IVF in the UK. So I think now, I'm losing count, to be honest. I think we've got about 15 clinics in the UK, and then we've got 1 in the States and 3 in Spain. We're also the largest provider of NHS-funded IVF in the UK across all of our clinics, which means that if you are eligible for NHS-funded treatment, you can always inquire about how you can be seen if there's a clinic near you, which is quite nice because you can often avoid long waiting lists, which are often common in NHS units. So, for example, in Manchester, if you're eligible for NHS funding, we accept GP referrals and we will double check your eligibility. But that will mean that we can see you within a couple of weeks and you can start treatment in a matter of 4 to 6 weeks, perhaps, whereas you might be waiting on an NHS waiting list for over a year just down the road. So actually, there's lots of opportunities to get NHS funded treatment if you are eligible, but also, of course, if you're wanting self-funded treatment. So, of course, the initial part is getting the right diagnosis, and this largely applies to couples who've been trying to conceive for a while. So in general, we would recommend having some basic investigations after a year, and then definitely considering treatment at a 2-year mark. And the way that we can get you the right diagnosis initially, and the test that we would book in before seeing one of the doctors, is a blood test for an egg provider. So that would be to check the number of eggs that are left. So one of the ways that we do this is with a blood test called AMH. So AMH stands for anti-Mullerian hormone, and this gives us an indication of how many eggs left within the ovary. So in a normal menstrual cycle, so in a normal month, a female would produce 1 follicle, and then lots and lots of smaller follicles in the background. So there's always some follicles that come up in a cohort, in a little group, but one becomes what we call recruited, becomes very big, and that is the one that you would then release the egg from in a cycle. So on the walls of these follicles are some cells that release this hormone, and that's what we're testing for there. And it gives us a really good indication of how many eggs are left, and also tells us about your prognosis, so your chances of an IVF cycle if you were to go down that route, the chances of it working. Okay. The other thing that we would do if you are an egg provider is that we would look at an ultrasound scan. So it's a transvaginal ultrasound scan, and what we're looking at here is to make sure that there's no significant abnormalities, so things like a polyp or a fibroid, which are benign lumps within the uterus. Also looking for cystic changes on the ovaries. And again, we also count something which is the follicles, which I've already mentioned. By counting the follicles that are there within that cycle, they change all the time, as I said, but by counting the ones that are there in that cycle, it gives us an indication of how many eggs are left within inside the ovary. And then if applicable, so if there is a male partner providing sperm for the treatment, then we would do a semen analysis. And I think we have a video of a semen analysis that we are able to show you. So I'll just get that up now. So we often use very fancy equipment called a computer-assisted semen analysis, where we get accurate determination of motility. So here you can see the sperm swimming around, and it tells a little bit about the movement of the sperm. So what we want to know, first of all, is how many sperm are in the sample. So that's the concentration. The second thing that we want to know is what percentage of those sperm are swimming normally. And then finally, but least important, is what percentage look completely normal. Okay, so I'll just move this on. So once you've done those tests, we would then book you in for a consultation. So all of these are booked in right from the outset by our very helpful GEM team. So that's the General Enquiries team. And your consultation can be with your doctor of choice or the next available. And at the consultation, we'll go through these tests for you. So we'll talk to you about, first of all, what you're trying to achieve. And that might sound a little bit odd, but sometimes it's appropriate to ask questions such as, how many children do you want? And sometimes patients are also, of course, coming from very different backgrounds. So some couples, single patients, would have had a complex history, and prior to the consultation, it is absolutely fine to upload previous notes and summaries from your previous experiences in different clinics, and the doctor can review that prior to the consultation, so that we've already got an idea of your background and the treatment that you've had, so that we can have a think about how we might change things to improve your chances going forward. So all of that is discussed at your consultation, and we'll come up with a management plan. And it might be the case that we can't necessarily decide absolutely everything at that consultation. We may give you two different options to think about, and then you can go away and have a think about how you might want to do your treatments. You might want to have another chat to the doctor before starting. Generally, what happens after the consultation is you're then contacted automatically within a few days by our Care Pals team. So the Pals are the administrators that support you in getting on to your treatment. So there's quite a few steps in between. The main things are some blood tests to check for infections, and that is mandated by law. And there's also a few consent forms to fill in. So the admin team will support you with that and any cost estimates, and discuss the different options. And we might also have packages which are relevant for you, which again, I think we've got a slide on at the end, and I'll go through a couple of the different options. So the IVF process, so if it is IVF that you decide to have, most of our patients are having IVF, but not everyone. The way that this works, we give you injections. So it works slightly differently at different clinics. In some clinics, you will start the injection straight away at the start of a period. In other clinics, we give you a tablet just before that, called a progesterone tablet, and then you then start the injection. So there's a little bit of a variety, but essentially you're on the injections for between 10 and 12 days, and they are stimulation injections. So they're called follicle stimulating hormone, and that is what is making your follicles grow. So the benefit of IVF and the reason that it's so much more successful than some of the other treatment types is that rather than producing one egg and one follicle, we stop the wasting process of the follicles where your eggs are stored, and we make them all grow. So your ovaries with these injections become like a little bit of a small bunch of grapes. So lots of these little fluid-filled sacs, and that's where your eggs are stored. So we can hopefully collect maybe ideally between 10 and 15 eggs from one IVF cycle. And of course, that would be like you trying to conceive for about 10 to 15 months, all within one menstrual period. And that's the benefit. So we give you all of those injections, and you add in a second one about halfway through that stops you from releasing the eggs. And then at the very end, we do one or two scans to check on the progress. And that determines whether you are ready for an egg collection. So if you are ready for an egg collection, then you take an injection, which is the most important one out of the whole process. So the timing of this injection is really, really important. So one, making sure that you take it correctly is important, but also making sure that you take it at the right time is really important. And also the clinicians in the clinics do a really good job of timing your trigger. Okay, so that's really important for your success in IVF. So we will organise that for you. Usually the nurses will call you and tell you what time to take your trigger. So normally that's quite late at night, and then 36 hours later usually is when you then come for an egg collection. Okay, and when you come for the egg collection, this is Rima just doing as an example of a monitoring scan. So Rima is Dr. Vajakova is the medical director of Care Fertility in Birmingham. So these are your scans. So this is a picture here of your egg collection process. So when you come for the egg collection, you are a small drip is put in your vein so that we can deliver the medications to you. So normally we would give you a strong sedative and a strong painkiller just before the procedure. That is called conscious sedation. So you wouldn't be completely unconscious with a tube down your throat. It's not like a major operation in a hospital. It takes about 5 or 10 minutes, and probably you're in the room for about 20 minutes, 25 minutes. Okay. So what happens is it's exactly like an ultrasound scan. We put the probe inside, we find your ovary, and then a small needle comes through the vaginal skin into the ovary, and we basically suck out all of that fluid. And that's because the ovaries then, because of the weight of gravity and the weight of the ovary with all those follicles in, they then hang down by the sides of the vagina. So we can get to them usually relatively easily. Okay. So we then suck out all of that follicular fluid, and then that fluid then goes into the lab. And then on that day that we're doing that, your partner, if you've got a sperm provider as a partner, they would then do another semen sample for us, and that's the one that we use in the treatment. So then we then fertilize those eggs. So on the day we tell you how many eggs you've got, we fertilize those eggs, and the day after is when we tell you how many we've fertilized. Okay. So there are a couple of ways of fertilization. So one is conventional IVF. And another type of treatment is called ICSI. So this stands for intracytoplasmic sperm injection. And I think we've got a little video of this. So with ICSI, what we're doing is we're looking in the treatment sample and we're finding a good looking and moving, swimming sperm. And then what we do is we directly inject that into each egg. Okay, so we do that for every single egg that we've collected. So you can see that we're sucking up the cytoplasm there, or the scientists are, and then injecting that directly into the egg. Okay. The alternative way, as I said, is IVF, and with that we clean and prepare the sperm, and it becomes a clear fluid instead of a white fluid. And we then inseminate each egg with a set concentration of the sperm, leave it overnight in a dish in an incubator, and just allow it to fertilize on its own. Okay, so the day after, as I said, we will call you, we'll let you know how many are fertilized, and then what we then do is we culture the embryos. So there are a couple of ways of culturing embryos. So one is that we just leave it in an incubator, which is the standard way of doing it. And that is how we've been doing it for, 40 odd years. We put it in an incubator, we leave it, and then what we now know is best is to not disturb that embryo for 5 days. So we do something at Care called extended culture as standard. And we do this because we know that the embryos that make it to 5 days old are more likely to result in a healthy baby at the end. So that's called extended culture. It's become standard practice. And it does improve the pregnancy rates. So we're confident enough in our systems in order to be able to do that in all of our labs. Okay. So on day 5, we then check what you've got, and we look down the microscope and we grade it, and we tell you which is the best ones, and we then put the best one back and then freeze any spares. The alternative way of doing that is something called Care Maps. And I think we've also got a video of Care Maps, and it nicely shows the whole process. So with Care Maps, what we're doing is it goes into a specialized incubator, and we're taking a picture of the developing embryo every 10 minutes over a period of 5 days. So it forms this little nice video. So you can see all the cells there. They're all starting to compact now into what we call a morula. So this typically happens around day 4. And then now it's forming a blastocyst in the cavity. And you can see on the right-hand side there, it's starting to hatch out of its shell, and that's called a hatching blastocyst. So when it forms this, usually on day 5, day 6, this is called a hatching embryo, or a hatching blastocyst. So we want a blastocyst. So that's what we're aiming for in 5 days' time. So that process, Care Maps, is something that we offer. It is founded within Care in the UK. It's called time-lapse technology. And we've got loads of really good data to show the benefits of using Care Maps. So in the standard way I described before, we put the best one back first. With Care Maps, we get an individualized score for each embryo out of 10, which then aligns with a pregnancy rate. And we can then tell you for this embryo, you have an X% chance of it working based on 6,000 babies that have been born, and in a Care Maps incubator. That's how we know that from it's an artificial intelligence algorithm. So it works really well. It's been developed and improved over years and years, and it's an award-winning technology that Care has won lots of awards for, particularly for the AI component. So that there are a couple of the different ways we choose which embryo to put back 5 days later. So one is just by looking in 5 days. One is by using an algorithm or a computer, which tells us which is the best embryo, and that's Care Maps. And then the final way is called PGTA. So this is pre-implantation genetic testing for aneuploidy. And we've got another quite nice video of this happening. So in this, on 5 days, when it's formed a blastocyst, the scientists take about 4 to 10 cells, usually about 5 or 6 cells from the edge of the embryo. So this is part of the embryo that's called the trophectoderm. So this forms the placenta. And we know that actually the risk of this damaging an embryo is really rare at 0.05%, even though it looks like quite a significant procedure for a little embryo that you can't see with your naked eye to go through. Now, the advantage of this is it tells us whether that embryo is genetically normal or not. Now, this is important, and it's particularly important for patients that are 36 years old and over. And that is because we know that if you are less than 35, about half of the embryos that you create in IVF will be genetically abnormal. And that percentage of abnormal embryos increases as you get older. So, for example, if you're 43 years old, that goes to 90% of your embryos are genetically abnormal. So you can see how it might be really important to definitely know for sure which is the good embryo to put back if you're a little bit older and you're more towards 40 or over 40. And we generally offer this for 36-year-olds and over, and it can be useful also for reducing miscarriage. So the HFEA, who governs IVF clinics, they rate all of the interventions that we use, and this is rated as green, so a good thing for reducing the risk of miscarriage. And it can also be useful for patients that want to reduce the risk of having a child affected by a chromosomal condition, because it tells us whether each embryo has got a normal number of chromosomes or not. So therefore reduces or avoids the risk of having a child, for example, with Down syndrome or another chromosomal syndrome. Okay. So that's an individual thing, something that a consultant would talk to you about at initial consultation. And if it's relevant to you, it's not useful for everybody, but can be useful for certain groups of patients. So as I said before, we now have really good freezing technology. So one of the reasons that IVF has become so much more successful than 30, 40 years ago is that the ability to freeze and the technology that we have to freeze embryos has really, really progressed. So the survival rate from a frozen embryo is over 98%. So it's actually really unusual that we see an embryo that doesn't survive. And we freeze all of those spare embryos. We put them back then in a frozen cycle if the first one doesn't work. So 5 days later, you've had your egg collection. 5 days later is when we're either biopsying the embryo, we then freezing the embryo, and then getting the results of the genetic testing, and then putting it back in a subsequent frozen cycle, so in a different period later on. Or you're having the fresh transfer, and what we mean by fresh is that you've had your egg collection, we're assessing the embryos, and we're putting them back 5 days later. And that process of putting an embryo back is relatively straightforward. So again, takes about 5 minutes or so. What we do is we load the embryo into a little syringe, into a little catheter, a tube, which we then put through the neck of the womb into the uterus and inject it at the top of the uterus. So we make sure, usually with an ultrasound scan, that we're putting it back in the right place. And the chances of that working per patient is really dictated by a patient's age. So with the consultation, we would give you an relatively accurate idea of what your chances were per transfer. Now, the important thing I always say to my patients is that you need to really think about your chances overall from all of the embryos that you've got and from one egg collection, and not focus so much on just the first transfer. Because most patients, unfortunately, won't get pregnant and have a baby from the first transfer. Okay, so for young patients across the UK, our clinics are above average in terms of the pregnancy rates. But still, having said that, the live birth rate for a young patient is generally around 35-37%. Okay. Now, the pregnancy rate is a little bit higher, and that's because, unfortunately, not all of those pregnancies make it onto a healthy baby at the end. So you really need to think about not just that first transfer, but your subsequent ones after. And it is important to think about PGTA in certain groups of patients. So, for example, we know that if we biopsy that embryo and we know it's a good embryo, the pregnancy rate is actually as high as 55%. So it can be really beneficial for certain groups. So that's just, again, another picture of the transfer and the procedure. Your partner, if you have one, or a friend, can come in for this procedure, not for the egg collection, but for the procedure of the transfer. And it's quite a nice thing to watch after going through all of that, to see the embryo going in on the screen. So now I'm just going to spend some time talking about IUI. So IUI is a popular option, particularly for same-sex female couples, also for single patients, but also for heterosexual couples that, for example, may struggle with intercourse. But most of our patients are same-sex females that choose to do this. We would support you if you needed access to a sperm donor, and we've got a few banks that we work with, I think, that we've got later on. So in an IUI process, sorry, just to go back, how it works is it's a little bit more straightforward from a medical point of view, and it's often why it's chosen. It's less invasive. You would essentially phone us with day one of your period when you're starting treatment. You come in for a scan, usually around days 10 or 11. We check the size of the follicle that you've got there on that cycle. And what we then do is we determine when you're ovulating. And then once we know when you're ovulating, we then put the sperm back, usually the day after. Okay. Sometimes we might use medications to help you ovulate. Sometimes we use medications to help support the pregnancy later on. But I would say the majority of patients choose to do it completely naturally. But again, it's very individual depending on your particular medical history. Okay. In general, the pregnancy rates from an IUI for someone who's less than 35, for example, are about 12 to 15%. So in general, we recommend thinking about doing 3 cycles in a bulk, so that you've got kind of an aim of over 3 months to think about this, and then review things after 3 months. Shared motherhood is actually something really nice, I think, or sometimes called reciprocal IVF. So in this scenario, a same-sex female couple, one of them would become one of them would carry the pregnancy, and one of them donates their eggs to the other partner in order to be able to do that. And sometimes we then have patients that then come back and then switch and do it the other way around. So it's really nice because both can feel that they're part of the journey in starting a family. It is a specialised part of the process, and the reason for that is the way that our law works in the UK is a little bit old-fashioned, which means that we need to do a really good job of making sure that both parties are the legal parents, and therefore there's quite a few forms and checks to do to make sure there isn't any a problem with that. So the donation team are the ones that then would support with that process, just to make sure that everything is correct before we go forward. Okay, so it's not part of the standard IVF process. From a treatment perspective it is, but you have this added step at the start with the donation teams to help support with all the right paperwork. So donation with care then. So I was mentioning that we do have a sperm bank ourselves. So actually the sperm bank has been increasing over the last year, I would say, and we don't have a significant wait for a sperm donor at the moment. I think probably 2 or 3 weeks is the maximum that you'll be offered a potential match. The difference really is that with Care's Bank, we only offer 1 vial of sperm at a time, whereas with external sperm banks, you can buy multiple vials of sperm, which means that if you did want to consider further treatment in the future, it is then more guaranteed to have a genetically related sibling for that treatment. So that's really the only major difference. We can't guarantee the same sperm donor if you came back for further treatment. So in order to get sperm externally, it has to be one of the banks that we partner with, because we have to make sure that they agree with all of the checks that we put in place to screen their donors. And we work with the ones listed on the screen there. Okay. Egg donation. Again, we have our own internal egg bank, and we don't work with an external banks because we have our own. These are all frozen eggs. So these are patients that have been through a similar process to what we've described with the stimulation and an egg collection, and they're donors that have been screened to be suitable. So we check them in the same way we do for sperm donors for infections, but also common genetic mutations that happen within their ethnicity. So for example, cystic fibrosis, thalassemia, sickle cell. So all of those kind of things are screened for. And we also look at all of their chromosomes as well to make sure that there's no significant genetic problems that might be passed on to any offspring. They go through counselling and then are then allowed to be a donor as long as there's no problems from their medical, genetic or family history. We then freeze their eggs after the egg collection, and you would then have an appointment after a consultation if you require donor eggs with the donation team, and they would go through the next steps and the consent forms. And once you're all ready and registered for the egg bank, you then get access, and essentially on there you get to see what's available, and you just select your eggs off there. Okay, then it takes about 6 weeks for those eggs both to get to us and for us to sort everything out for you to then start your treatment. So often it can be quicker than that, but we say 6 weeks as a general rule between you selecting your eggs and you starting your treatment. So these eggs could be in any of our clinics around the UK. Okay. You only get limited information about sperm or egg donors in the UK. So typically it is hair colour, eye colour, build, ethnicity, and skin colour. So you don't get a huge amount of information. Okay. We do have an egg donor program in our Spanish clinics as well for patients that are interested. We do have a big egg bank, but there is a international shortage of egg donors. So it's just about being aware that there might be a bit of a wait to find a particular egg donor, or particularly if you're after a specific characteristic or ethnicity, that can take quite a bit longer. But again, the donation team can answer those questions as to what we might have at the moment. We have a surrogacy team within Care. I personally see a lot of surrogacy patients, as it's an area of interest of mine. and we have won this award for Surrogacy Clinic of the Year for quite a few years in a row now. And we do have a great surrogacy team that can support patients through what can often be a little bit more of a challenging journey. And there's quite a few hoops to jump through with surrogacy, both from a legal standpoint and making sure that what we call the intended parents, so the patients wanting to become the parents, that making sure they become the legal parents is a little bit more complex than in an IVF situation. So that's why you need a separate team to be able to support that you've had all of the legal checks that you need, counselling and so on. So there's a couple of different types of surrogacy. In the main, these days, we tend not to use the surrogate's own eggs in the treatment. We tend to use donated eggs, and then the surrogate just has the transfer from those created embryos. With surrogacy, the important thing to realise is that you need to quarantine if there is a sperm provider, of course, which there would be. The sperm needs to be quarantined for 3 months. So we do screening at the start, so infection screening. We have to then wait for 3 months whilst that sperm's in storage and repeat it. So again, there's a few more steps in the process that can make it a little bit a longer journey, which is why we offer you extra support in that. We are not legally allowed to help support you in finding a surrogate. So there are a few surrogacy charities. So the main ones are Surrogacy UK, Brilliant Beginnings, COTS, and there's one more, and I'll remember, My Surrogacy Journey. So support at Care, we have an app which is called Salve, which you can download on app stores. And this helps support you in appointment reminders. It will help support you with payments, that kind of thing, keeping track of what you should be doing when, patient information. So it can be a really nice way of keeping track of everything that you need to do. And soon this is the way that we'll also be managing medications, but not quite yet. So we have payment packages which help you fund IVF and manage it. As we know, it can be really difficult and for some patients expensive. So there's a couple of ways that we can do that with Care Fertility. So they are a separate kind of department that support with these assessments to make sure that you're eligible for the package. So there's one way you can get up to 2 egg collections and all of your frozen embryo transfers included, and that's called the multi-cycle program. And there is one where it's up to 3 egg collections and you get money back if you don't have a baby at the end of the treatment. Okay. And just to say as well is that these are available on interest-free credit, so that you can pay it over 12 months. We currently have an offer for just £449, which is actually really good value, and it includes your ultrasound scan, semen analysis, AMH, and your consultation. So it's a significant discount that we've got at the moment, and this offer just ends actually in a few days' time on the 31st of July. Okay. So we support you. I think the main support during your IVF treatment, so before your treatment, it's really the admin team, our Care Pals team, that will contact you and discuss the different options and, as I said, help support you getting onto your treatment. Once you're on your treatment, it's our nursing teams that will support you through that. And we also have a team of counsellors. And if you're a patient with Care Fertility, you can have up to 3 free counselling sessions. And this is just a summary really of the other different support systems we've got in place. So we've got the new patient inquiry team, we've got a resource hub, social media, and we've got some care forums as well, which you'll get access to. So that's reached the end of the presentation. What I'll do now is I'll just take over and have a look at some of the questions. So let me just go to the more initial ones. So what is the typical amount of viable blastocysts at the end of a cycle on average? So on average, I would say it's probably about 2 or 3 blastocysts on average. It's very, very variable though. So some people get 8 or 10, some people don't get any. So of course, it's really variable. The main thing that determines your success in IVF is the number of eggs that you get. So that's why it's really important to have a really good plan for your stimulation at the outset, so we can maximize the number of eggs that you get. And the important thing to realize in IVF is that the number of eggs that you have at the start is very different from the number of blastocysts that you have at the end. So of the eggs that you've got at the start, 8% of those fertilize. 8% of them roughly are the right type of egg. Usually about 70% of them would then fertilize, and then about half of the fertilized ones become a blastocyst. So you can see if you're starting off with 10 blastocysts, you might have 10 eggs, you might have 2 or 3 blastocysts at the end. So what is the success rate of fertilization? So generally about 70%. Blastocysts, as I said, is about 50% of those that fertilized. What is the minimum sperm concentration requirement for ICSI? So in order to have IVF, we want the sperm concentration and the sperm motility, so the sperm movement, to be normal. If that's abnormal, we would then recommend the sperm injection. And in general, as long as there are sperm in the sample, so even if you've only got very occasional motile sperm in your sample, we can generally still do ICSI. It might be the case that if your sperm is less than 5 million per milliliter, sometimes even less than 10 million, depending on the other features, we might recommend doing further investigations, because it might be the case that we can do something to help with the sperm side of things to improve your chances in an IVF cycle. So ideally, we want to know what the cause is of the low sperm count, and hopefully improve that before then moving on to an IVF cycle. So there's no minimum number, but ideally we need to know why it's so low in the first place. Have you had any cases where you found sperm from someone who has azoospermia non-obstructive? So yes, so if you have azoospermia is when you've got no sperm in your sample. So obviously that's a really upsetting and stressful thing for a couple or a man to go through. Now there are treatment options available, and that is again really individual. So we would do a basic hormone profile and some genetic testings on that man to understand the cause and how severe the reason for the azoospermia might be. So if you've got a hormone profile and what we call your FSH is extremely high, we might know that actually your chances of getting sperm from the testes is going to be quite low. So we would do those tests and help support you with making a decision. But there are treatment options available. So there's something called a microteasy. In general, that retrieves sperm in about 30 to 40% of cases, but sometimes up to 50%, depending on which literature you read. And again, depending on the cases. So this is a procedure which is not done at Care, but we can refer you for it with a urologist who finds sperm in the testes using a microscope. Is PGTA available through the NHS or only privately? So it's not funded through the NHS anywhere in the UK, but you can in some clinics pay for that as a top-up, so you can get your NHS IVF funded, and then you can pay for the PGTA component yourself. That isn't the case everywhere. Unfortunately, for example, it's not the case in Greater Manchester. The NHS don't allow patients to mix NHS and private funded treatment. That is something that we're really campaigning against at the moment, because there is a bit of a postcode lottery with that. And of course, a lot of patients are frustrated that they can't just pay for bits if they've only been given one cycle and they want to maximize their chances. But it's worth asking your local clinic. Does transferring 2 embryos increase the chance of implantation? So in general, it does, but ideally we avoid it. So and it's not such a dramatic increase in your pregnancy rate than you might think. We avoid it because the risk of a twin pregnancy is really significant. So about 60% of twins are born preterm. You're significantly more likely to develop preeclampsia, which is a significant blood pressure problem, gestational diabetes, and the babies are significantly more likely to need to go to the neonatal unit when they're born, and you're going to need to go to the hospital every 2 or 3 weeks for scans, and it causes really often severe nausea and vomiting in early pregnancy. So really, these are not nice pregnancies. They're not safe for the babies either. So we avoid them. Now, there are cases where we do put 2 embryos back. So it's really individual based on you, and particularly the main factor that decides this is a patient's age, but also whether there are any other risk factors within that particular patient's history, which might want us to avoid a twin pregnancy more. So if someone's had lots of operations on their uterus, we don't want them to have a twin pregnancy. Okay. How long do you have to wait from egg collection to a frozen embryo transfer? I'm told there is a risk of, if there is a risk of OHSS. So this is a good question. So the main risk with IVF that we want to avoid is something called OHSS. So this is ovarian hyperstimulation syndrome. So this is where the body over-responds to the injections that we give you. Now, luckily, it only happens in about 10 to 12% of cases, and in the majority of those cases, it's mild. It's rare to need to go to a hospital with it. But the main way that we avoid this, and the main way we avoid patients becoming unwell, is not putting an embryo back on day 5. So we freeze all of the embryos, so there's no fresh transfer. And depending on when you have that embryo put back really depends on the situation. So if someone has recovered really well and they've had a withdrawal bleed after stopping their medication from the egg collection, and they're feeling great, and then you could potentially then come back the next cycle and have an embryo put back. However, if someone's developed really significant serious OHSS and unfortunately have ended up in hospital, then we might want to wait a little bit longer before making you pregnant, because the difficulty is that if you are pregnant, the hormone that is released from that pregnancy drives the process of OHSS, so it makes you more unwell. So it's a bit of a vicious circle. So we will be guided by your clinical symptoms, but in general, it's not too long a wait. Given over the overall rate, what are the steps in the process that have the greatest risk to fail? Again, that's really individual on a particular patient's results up front. So I would say that the main thing that you have to consider is if you've got a lower ovarian reserve, if you've got a lower AMH at the start, then you've got less chance of eggs to be collected, and then less chance of blastocysts. So it's not guaranteed that you would have a blastocyst to transfer. So it really depends on the egg number is the key and crucial thing. So understanding that and getting an individualized idea is probably what's best. The rest of the risks in IVF and the process are really quite minimal. So failed fertilization, when none of the eggs fertilize, only happens in about 2 to 5% of cases, depending if it's IVF or ICSI. Cancelling the cycle happens in about 10% of cases. So that's where you don't have an embryo transfer. So again, it's variable and depending on the patient. Do people with PCOS have a frozen embryo transfer, or can it be fresh? So it can be fresh, but it really depends again on your AMH and your response. So we can do a fresh transfer as long as you've not over-responded to the treatment. So I think we've been through all of the questions, and we're at 45 minutes. So what I'll do now is I'll hand over to Sam. But if you've got any further questions, just pop them in the chat and speak to the general inquiries team, and we can answer them at a later date. And hopefully I might see some of you at a consultation if you're local to Manchester. Okay.